Hello, I hope you're well. And in this session, we're going to do upper respiratory tract infections, again, focusing on epiglottitis and COVID-19. My name is Unibera, and if you're new, we encourage you to subscribe, but also to watch all the way to the end and leave a comment. If you're a returning member and you've not yet subscribed, please do so. So for those who are joining our sessions, this YouTube channel focuses on lessons, lectures, and sometimes we do bring experts who talk about healthcare. So be with us if this is your area of interest. So we began explaining different upper respiratory tract infection, and you can refer back to our various um, classes to just learn more about, including sinusitis, we talked about adenoiditis, tonsillitis, and so on, basically among the many upper respiratory tract that are considered important. So for the respiratory system, we have two segments. We have the upper respiratory tract and then we have the lower respiratory tract. So on the upper respiratory tract, this is where we got the nasal cavity, we have the pharynx, we have the larynx. And in here is where we are focusing for the upper respiratory tract. And you have highlighted several illnesses pertaining to this that for some we've already discussed. So we've already done rhinitis, pharyngitis, sinusitis, laryngitis, tonsillitis, and adenoiditis. So in this class, we're going to focus on epiglottitis and COVID-19. Now, you may be wondering, what about the lower respiratory tract? For the lower respiratory tract, the illnesses are very many and we've actually handled majority of them. So if you refer to our playlist that we have written in our channel, that is the respiratory disorders, you get to meet different diseases that affect the lower respiratory tract, including pneumonia, asthma, status asthmaticus. We've also discussed on bronchitis, summer bronchiolitis. We've also done lung cancer. Basically, we have expandedly checked on all these illnesses pertaining to lower respiratory tract. So you can listen in, check more there, read, refer, and get to understand how the lower respiratory tract illnesses behave, both in terms of pathophysiology, clinical manifestations, signs and symptoms, and even the management. But in this class, we would like to just focus on two illnesses, and that is epiglottitis and the COVID-19. So let's begin with epiglottitis. So epiglottitis is coming from the term epiglottis. And epiglottis is a flap of a tissue that is at the base of our tongue, and it's normally important that it prevents food from entering the trachea. So when the epiglottis gets inflamed, we get a disease we call epiglottitis. So in simple terms, we can say epiglottitis is the inflammation of the epiglottis. Epiglottis is a flap of tissue that is found at the base of the tongue, and it's normally exists to prevent food from entering the trachea. Also, again, just like where we mentioned in the case of the previous illness, in the adenoiditis, that it affects children, normally children aged 1 to 5 years, commonly affects them, but it can also happen in adults. So we are told epiglottitis has an abrupt onset and the condition can occur mostly during cold season or season where the weather is very cold, the temperatures are very low, like winter seasons. They tend to lead to high epiglottitis rates. It's normally considered an emergency situation because it can progress rapidly to completely block the airway or obstruct it. And because of this, you can be treated as an emergency illness to just work on how we can open the airways and to allow air to get back. Now, looking at the anatomy, where is the epiglottis located and how does it look like when it is now inflamed? So I would like to refer to our respiratory system here. Like we are saying, we are focusing on the upper respiratory system. So we got the tongue, and as we are going downwards, then we get to meet the epiglottis, the flap of tissue that closes the trachea when we need to swallow. So this is our healthy epiglottis here. So when it covers the respiratory system part, the first part that gets covered is our vocal cords, then the trachea automatically is covered. But then when there's epiglottitis, this tissue gets to be inflamed, so it swells up, and because of this, it can't properly like do its role. So because it's swollen, automatically it blocks the airways, and because of this, the child or the client is not able to breathe well. So causes of epiglottitis, it can vary from viruses to bacteria. However, we have the common virus that causes epiglottitis, and this includes the Haemophilus influenza type B, which normally is known for a viral infection we like to call influenza. But then we have thermal injuries, like in case someone has inhaled heat, it can also cause inflammation and the epiglottis can swell up. There's also injection of corrosive chemicals, which can also react in form of inflammation, and autoimmune status, where the person can suffer from autoimmunity and it can stimulate some reactive effects that can lead to inflammation and swelling. Now, if you want to check if the epiglottis is undergoing inflammation, then we can also do a direct visualization by the use of a laryngoscope, where we use a laryngoscope to just check directly on the epiglottis if it's swollen, if it's tender, if it's turned red. Because of the process of inflammation, you can use the laryngoscopy procedure for that. But then we come to clinical manifestation. How does the disease manifest itself? So one of the clinical manifestation that we can look at here is the case of sore throat. The patient can also present with agitation. We can have tachycardia, tachypnea. So tachycardia, this is increase in heart rate, and then tachypnea, this is increase in the breathing rate. But this is a client that can also show signs of drooling, difficulty or pain during swallowing. So remember the case of dysphagia, where we are talking about a client struggling to swallow because of the pain around the neck area or the inflammation of the tissues around the neck. There's also a global sensation or a feeling of a lump in the fourth area. Of course, this is due to the swollenness of the epiglottis at that particular time. This client can also present with dysphonia, that is muffled up voice or loss of voice at the end of the day. So dysphonia is uncomfortable because the client is not able to pronounce words clearly, or they're not able to pronounce words well, or the vocal cord get also to lose their abilities. The patient can have dry or no coughs, but then this now presents the symptoms of dyspnea. In other moments, you can get fever or increase in temperatures. You can have case of fatigue or malaise. Then in other cases, you can have tripod or sniffing postures for the children with a noisy breathing, that is stridors. So this is a list of the clinical manifestation that can present up in an epiglottitis client, from the case of sore throat, agitation or irritability, tachycardia, that is increased heart rate, tachypnea, that is increased breathing rate, difficult in swallowing or painful swallowing, a global sensation, dysphonia, dyspnea, fever, malaise and fatigue, the sniffing posture, and stridor. So these are manifestations that can be observed in an epiglottitis client. Now, when it comes to management of epiglottitis, remember we mentioned that this is usually treated as an emergency, because remember, when the epiglottis swells, it's going to block the larynx and the trachea. So that means air is not flowing easily, or it's not going through the respiratory system. So this client can have very high chances of suffocating or going through hypoxia. So number one, when you discover this client has epiglottitis, it's advised that you immediately admit them to the facility so that you can observe them and undergo critical interventions. But then while this is happening, you avoid any form of instrumentation, like no insertion of depressors or other instrument that can provoke airway spasms and lead to further respiratory compromise. There's also need to monitor any form of respiratory fatigue, either by visually assessing the client, or continuously checking via the pulse oximeter that the client oxygen levels are not going low. So we'll need to always have an oximeter monitor on this client. And then we are advised to avoid supine position, as normally this can affect their respiratory status. We know that with supine, it means the client is sleeping on their back. So when the client sleeps on their back, It means the chest cavity is reduced, so they can't properly take in enough air to promote gaseous exchange. So avoid superposition, and then have equipment and personnel available for immediate intubation if it's needed. Remember, while the epiglottis keeps on swelling, it's blocking the larynx and it's blocking the trachea. So in this case, our client can be at risk of respiratory distress. So have emergency setup put in advance in case you're worried that this client can go through distress. And then start intravenous antibiotics after you have collected specimen for culture and sensitivity. So start IV antibiotics to start clearing any form of viruses or bacteria that you're questioning. But then there's an advice of medication that we can initiate in case you're worried about Haemophilus influenza, including ceftriaxone or the use of third generation cephalosporins. We can also do ceforexims, or you can have cefamadols. So these are options of choices that can be implemented to assist with clearing of infection that is leading to epiglottitis. Look also at fluids volume. So in this case is correct fluid deficits with IV fluids again. This can help us clear any form of excess mucus production. So you can get fluids to help with clearing, loosening this mucus and enabling clearance or drooling it out. We are informed to avoid any sedatives, and the reason we are avoiding sedatives is because sedatives are known for causing respiratory distress. So already this client is risking airway blockage, so we do not want to give sedative as it can go ahead and worsen the situation. The other bit is pain management, where we want to eliminate this by administering analgesics and antipyretics, given examples of acetaminophen and ibuprofen to reduce fever and pain. And then we can administer corticosteroids to just eliminate the inflammation and reduce any risk of edema that could be happening around the throat. Oxygen therapy is good because we know with oxygen, then we are able to supplement for the hypoxia that is setting in due to the improper oxygen exchange that is happening. But also humidification can help us cool the airway. It can eliminate chances of unnecessary bronchospasms and ensure that the diameters are well dilated to just promote, airway exchange or airway entry and exit. But then, like I said, this is an emergency case, and therefore you need to set up resuscitation equipment to be available on the side, just in case this client needs critical intervention due to the assessed status of respiration. So if you detect any risk of distress, then it's good we prepare for endotracheal intubation, or you can prepare for tracheotomy for the purpose of eliminating severe respiratory distress. And we've seen that part of the causative agent for epiglottitis is influenza. Then we need to ensure that the child is also up to date with their immunization schedule, specifically influenza conjugates, the Haemophilus conjugates, so that they are immunized and we reduce the risk of contacting, further infections or further influenza-related microorganism that can stimulate or keep up the inflammation process for the epiglottitis. So keeping up, that is COVID-19, what we commonly call the coronavirus. So coronavirus is an upper respiratory tract infection which is caused by a viral group known as coronaviridae. And the symptoms for coronavirus are similar to a syndrome known as SARS, or severe acute respiratory syndrome, which happened or occurred in 2003. So it's known that the reservoir for coronavirus is actually among the Chinese host bats, which are known to be the natural reservoir for coronaviruses. So when it comes to incubation period, that is between the exposure into the starting of symptoms, it can start immediately after 2 days all the way to 5 days. And to just remind us is that coronavirus or COVID-19 was actually declared a pandemic in the year 2020, and it took a lot of intervention and measures to just contain and prevent transmission of this disease. So ways of spreading coronavirus are highlighted that this is particularly airborne. However, close contact to a person who has been exposed or infected can increase chances of transmitting this disease. So ways of spreading coronavirus are reported to be close person-to-person contact through activities like hugging and kissing, but also direct contact with the respiratory secretions and body fluids increases the chances of spreading corona. Cough and sneezing are one of the most known ways of spreading coronavirus now that it's airborne, but also touching infected and contaminated surfaces seems to also increase the chances of contacting coronavirus. Non-symptoms, or what we are referring to as clinical manifestation. So there is the report of fever. So the client can report episodes of fever, reporting more than 38 degrees Celsius. However, in some adults, they can present as a febrile in the beginning part of the illness, and then as it progresses, the temperature can start to become observable or can be measured. Malaysian fatigue or general body weakness is also highly observable or present, and you can have neurologic symptoms, for instance, headache. So in headache, there are those who complained that when they were experiencing headache, they also tended to have memory loss, or they seemed to struggle with reasoning and comprehending concepts. So neurological effects came with several other symptoms apart from just headache. Then there's muscle and body ache or general body pain, which was also present in some client. There's also dizziness, cough was present. That was like a cardinal symptom. We got shortness of breath or dyspnea, running nose and congestion. In other client, there was presence of diarrhea, nausea, and vomiting, but also we could detect change in sense of smell and tasting. So brain fog, this is where I was mentioning on about neurological symptoms. So there could be brain fog where some will report that they have difficulty in thinking or they are not able to focus properly. So if you look at the common symptoms, this is where we were mentioning here that common of the symptoms here is this is what you can immediately see in the first 2 up to 5 days. However, there are those that seems to come up later in severe cases. So dilated fever, loss of appetite, fatigue, alteration of smell, shortness of breath, coughing, muscle aches and pain. However, in severe cases, the client now can have other difficulties, like difficulty in waking up or confusion, bluish face of lips that is now like leading to cyanosis, coughing up of blood, persistent chest pain, decrease in white blood cell levels, and then we have kidney failure and extremely high fever. So this is observable in the severe cases. So when you look at coronavirus or COVID-19, what was more observable is the common symptoms. But if you are very keen, you found that when it was leading to complications, you will actually start detecting most of these severe symptoms that will come up. So when it comes to diagnosis to determine whether the patient is a positive COVID-19 case, then there was ability to do PCRs, which means polymerase chain reaction test. So this is an antibody check, which will help us detect the antibodies that are highly produced when a client has COVID-19. And so we could do PCR to determine that. But then we have the rapid antigen test, which are also very good because you can self-test. These were like self-test checks through the swab, and you could determine the status of the client. So there are different approaches that were done, but there are those who could also do symptomatic analysis and and they could just confirm if they are COVID case or not. So risk factors for COVID-19, we could have age. So advanced age was seen as one of a risk factor that could indicate high risk of contacting COVID-19, and the age of above 65 years was among the riskiest because we explained that the higher the age, the lower the immune ability or the immunity. And so because of this, the client will be more highly exposed to contracting infection compared to younger ages like youth or basically middle-aged. Then we have pregnant mothers or pregnant women. So pregnancy also has an impact on the body because of the physiological changes that come with pregnancy. Partly the immunity also gets to be compromised, and so chances of getting infected are also high. History of smoking and generally population that is immunocompromised, like clients who are cancer diagnosis or cancer diagnosed, tended to be more at risk of contacting COVID-19. Then clients who had positive blood disorders, for instance, sickle cell illnesses. These are diseases that are known for lowering immunity too, and they tend to increase the chances of contacting coronavirus. And then we got congenital illnesses such as Down syndrome and cerebral palsy also were included as a risk factor for contacting coronavirus. So on the management, we were explained that the interventions we will give for the management of coronavirus were supportive and they were guided again by symptoms. So can talk about symptomatic supportive management for coronavirus. So one thing that was like critical when it comes to intervening was administration of oxygen, because you could see that this is an inflammatory illness, it's an infection, but then oxygen becomes critical because you want to salvage and avoid development of respiratory distress among the client. Then we got corticosteroids, which are known for lowering inflammation status among the respiratory tissues, and thus were one of the recommended management. Vaccination. So COVID-19 vaccines were critical when it came to handling the COVID-19 spread. So the brand of COVID-19 vaccines were quite many, and so it was advised that you can use any, but then discuss that with your doctor and get to agree which one is efficient for each individual. So there were examples, or we have example like AstraZeneca's, and AstraZeneca was like the most common. So AstraZeneca is good, but then you have other options of vaccinations against COVID-19 that you can have. So the best management was control measures to just prevent the spread of COVID-19, and part of it was isolation of patients. So any contacted client or client who are known to have been exposed were taken through isolation to just prevent spread of the illnesses. They were also quarantined for any patient who was exposed. We don't have, then we have travel restriction, that is both local and international travels. This was to just ensure that we don't have a lot of people moving from one region to another, which is seen as a risk factor of spreading this virus. Because if you move from one part to another, it's airborne. So we tend to breathe in and out, and this virus ends to exist in our environment. Then for healthcare workers, there's need to use personal protective equipment to just be safe, protect oneself, and to ensure that we don't get exposed to contaminated surfaces or fluids. Hand hygiene was important, especially after touching surfaces or being in the exposure for so long. Then hand washing with soap and water was very important. But in some cases where water is limited, then you can opt to just do sanitization, that is getting sanitizer, applying on the hand, and using the social technique to just apply and to make sure that you're protected. Then there's avoiding of congestion and keeping social distance more than 1 meter is important. This is because keeping social distance makes sure that we prevent any occurrence of congestion, and therefore there's no contact, or there's no direct body to body contact that can easily risk us from inhaling the virus. Then covering of our mouth and nose in cases of sneezing. Repeating, this is an airborne disease, so it can easily spread via airborne, and because of this, when we cover our mouth and nose when we sneeze, we reduce the trajectory of how far the virus can be sneezed out. So if we cover, then we limit it to just within our locality, our region where we are standing or seated. So this hygiene was to ensure that we avoid spitting or spreading it or splashing it on as many surfaces as possible. On the complication bit, coronavirus is known to complicate into what we call acute respiratory distress, or RDS. So this is a state whereby the lungs are working poorly, or they're not able to sustain their physiological function of exchanging gases or properly balancing the oxygenation and the exit of carbon dioxide into the environment. So in this case, the client tended to go through severe hypoxia, or the client some of them will complicate into respiratory failures, and they'll end up into high density units or acute or critical care units. And in this case, unfortunately, for particular, some of them will die. So the complication that you're talking about is acute respiratory distress. Thank you for keeping up to the end. Reminder, please like the videos if it's really good. Give us a comment, share with your colleagues, but also don't forget to subscribe. Thank you for staying with me all the way to the end. Until we meet again in the next class. Bye bye.